بسم الله الرحمن الرحيم. رمضان كريم عليكم وكل عام وانتم بخير. This is Assistant Prof. Dr. Al-Dolaymi, Consultant Orthopedic Surgeon. We will talk in this lecture about the benign bone tumor. This lecture is a continuation of the previous lecture in which we talk about the basic principles of bone tumor in general. The commonest benign tumor and the first tumor we will talk about is the non-ossifying fibroma, which is also called fibrocortical defect, and also sometimes we call non-ossifying tumor. It is the commonest benign lesion in the childhood, and it is developed due to fibrous tissue which is replaced by bone when the child grows. This failure leads to formation of fibrous tissue in the bone and will replace the normal bony structure. So it is an asymptomatic lesion and rarely cause fracture and will disappear when the child grows up. In imaging, we will see a solitary lesion at the metaphysis, eccentric location with multiple lesions rarely found, and this can be confirmed by CT scan. Histologically, there is fibrous tissue with scattered giant cell. Management: it is a benign lesion, not change to malignant tumor or cause fracture. So for this reason, the management will be conservatively, and the lesion can heal spontaneously as the child grows. But what we need to follow up and re-evaluation after 6 months. If it is persist, or if it is become larger, or if it is complicated by a fracture, so in this case we need to do curettage and bone graft. The fibrous dysplasia, it is a developmental disorder of the bone. It is occur when the trabecular bone is also replaced by fibrous tissue. It is of 3 types, which is single bone affected, and which is called monostotic lesion, and if it is multiple bone affected but in only one limb, called monomelic, and monomelic. In case of multiple bone in multiple parts, will cause polystotic. So it is monostotic, monomelic, polystotic. It is a variable size and can be small size, asymptomatic, and maybe large size will cause deformity, which we call it Shepherd crook deformity, اللي نعرفها أيضا بعصا الراعي يسموه Shepherd crook deformity. It mainly affects the long bone. It is about occur in the long bone. It is about 5 to 10% affecting the long bone, and also the bone, the fibrous dysplasia can be transformed to a malignant tumor in case of in a percent of 5% to 10%, and will be transformed to fibrosarcoma, chondrosarcoma, and osteosarcoma. It may be also associated with coffee spot in case in case of Albright syndrome, in which there is also a precocious puberty. In imaging, there is a radiolucent lesion alternate with a path of ossification, which give the appearance of ground glass appearance. This is multiple osteolytic lesion. Histologically, there is fibrous tissue with a woven bone and also giant cell. Management: small lesion need to only follow up and re-evaluation after 3 months. Large or moderate lesion need to surgical excision with bone graft and curettage and larger lesion need to also in case of recurrence, and larger lesion need to removal of the excision of the tumor, curettage, bone cement, and internal fixation. Osteoid osteoma, it is a developmental abrasion. It is a benign tumor of the bone, and it is a developmental abrasion or reactive growth rather than a true neoplasm. It is a very small benign tumor with a neurovascular nidus inside. It affects 50% for the long bone of the tibia and femur, and it is rarely seen in a flat bone. It divided into, according to the site, into cortical, which is appear in the cortex, cancellous in the cancellous bone, and subperiosteal. It affects teenage group, mainly affects male. It is less than 2 cm in diameter. It causes also pain, and this pain due to release of prostaglandin. So the diagnostic test, which is therapeutic and diagnostic, which is use of aspirin. There will be dramatic relief by aspirin due to the presence of high concentration of prostaglandin. So this use also as a diagnostic test. In case of there is suspicion and the patient develop from long standing pain in the leg, and in X-ray there is suspicion of osteoid osteoma, so we give the patient aspirin 300 milligram 3 times a day. If there is response, there will be dramatic response. and يعني قبل فترة حتى جاني مريض يعني سنة كاملة وهو يشكي من ألم في الساق. بعثت اكس راي، بالاكس راي شفت عنده كأنه اكو سسبشن مع الاوستيود اوستيوما، فبديت وياه اسبرين. فاجاني بعد يومين قال لي دكتور يعني انا صار لي سنة كاملة ما نايم ليلة كاملة، كله لازم اقعد بسبب الألم، عدا انه بعد ما اخذ الاسبرين يقول قدرت انام هاي 3 ليالي انا انام نومه مرتاحة وكأنه ما في رجلي شيء. This means that this is a dramatic response to aspirin. So I do surgery for him and removal of these calcification, or because it appears as a calcification, and send for histopathology will give the proof of the diagnosis. So this is the case. This is the nidus, what we call it nidus, and there is sclerosis around the bone. The diagnostic is by CT scan and histopathology. In histopathology, there is a well circumscribed mass of woven with osteoblast called the nidus, surrounded by reactive bone formation. Management confirmed by CT scan need to in-block resection, sometime under X-ray guide, sometimes CT scan. And there is some literature said that if there is the site is inaccessible, like in a spine or in we can't reach the tumor, so can be give him aspirin for a long time, but this is not practically exactly. So the best is to remove the bone in a block, or can be used other mode of treatment like laser and radiotherapy. Osteochondroma, it is also known as bone exostosis, bony exostosis. It is a common bone tumor. Appear as a mushroom shaped overgrowth cartilage at the epiphyseal site, near the epiphyseal, and its growth is in a reverse direction to the growth of the epiphysis. So this is the start, will growth in this way, and the femur is growth in this way. So leaving the tumor behind. Leaving the tumor behind. Imaging, we see it is clear by X-ray that there is a tumor as enchondral ossification arise in the metaphyseal diaphyseal junction, and it is clear. In case of malignant transformation, which is occur in 1 to 5%, 1 to 5% will convert to chondrosarcoma. So what we will see, there is an increase in the size of the tumor after maturity. Because the tumor is a cartilage and it appears in the physeal plate and it is part of the growth. So after the growth of the bone, the growth of the bone exostosis also stop. If it is increased after puberty, this means that there is a suspicion of malignant transformation. Or if there is a fragmentation of the cartilage, thickened cartilage, or if there is osteolytic in the lesion, this means that this tumor is transformed to a malignant tumor. Histologically, it appears as a sheet of mature bone cell with enchondral cells. Microscopically, there is a cup of benign hyaline cartilage, and in addition to with a bony ossification, a new bone formation on the inner surface. This is the new bone formation of the inner surface of the head. So this is a cartilage cup with a new bone formation behind, and even there may be a marrow and bone marrow. It is a complete bone structure. Management will be by surgical removal. Indication in case of significant symptom, if there is a growth after maturity, and if there is a malignant risk of malignant transformation. Simple bone cysts, it is cystic lesion of the bone, commonly affect child age group, typically occur in the metaphyseal area of the long bone, mostly the proximal humerus. Usually heal spontaneously and rarely seen in adult age group, and very rarely lead to fracture. Imaging, there will be well demarcated lesion with cortical defect or expansion. Without cortical defect and expansion, يعني الكورتكس هنا كاملة ما بيها defect وماكو expansion, ما في expansion here. With like this is a clear, well demarcated cortical or osteolytic lesion. Differential diagnosis, which is fibrous dysplasia, fibrocortical defect, osteodyostoma. Confirmed diagnosis by needle aspiration under X-ray guide or by CT scan. Management, usually there is no treatment and no management, and if there is a fracture, there will be spontaneous healing, so it will need, because of bleeding in the fracture will cause bleeding will fill the cavity and will organization lead to healing of the bone cyst. Other method of treatment can be aspiration and injection of steroid, and if it is the cyst is active one, large, and if it is near the joint, this will we do excision by curettage and bone graft. In case also of recurrence of the cyst, this need to curate and bone grafts. Aneurysmal bone cyst, it is type of bone cyst, can occur at any age and at any bone. So aneurysmal bone cyst, any age, any bone. It is progressive expansion cyst with thinning of the cortex. There is thinning of the cortex. This is the difference, because sometimes we ask you what is the difference between aneurysmal bone cyst and simple bone cyst. In aneurysmal bone cyst, there is destruction, there is expansion, extension, there is ballooning, and the demarcation is not well appear. For this reason, the aneurysmal bone cyst also caused a benign lesion with aggressive behavior. Benign lesion with aggressive behavior. So in X-ray, we see osteolytic lesion, which is eccentric with destruction of the capsule and ballooning and expansion of the tumor of the cyst. CT scan will be diagnostic. Differential diagnosis will be osteolytically, like in aneurysmal bone cyst, of simple bone cyst, hydrocyst cyst, fibrous, any cyst in the bone can be put in the differential diagnosis of aneurysmal bone cyst. Histologically, clotted blood and fibrous tissue with vascular channel with hemosiderin deposit management. If the cyst is big, we have to do curettage and bone graft. If there is recurrence, we do second surgery and remove the tumor, second bone graft, and may need to do fixation. Enchondroma, it is a benign tumor of hyaline cartilage. It may be arise within the medullary cavity. So we call it enchondroma, or on the surface of the bone, we call it subperiosteal chondroma. Usually it is solitary, metaphyseal in the short tubular bone of the phalanx mainly, and it is less than 3 diameter. Multiple tumor can be part of Ollier disease, which is the enchondromatosis. Enchondromatosis, this is the Ollier disease. You see the fingers appear due to multiple lesion. Clinical feature, it is most enchondroma are asymptomatic and detected incidentally. Malignant transformation common in Ollier disease and in multiple lesion. And acral bone is the most common primary hand tumor, usually solitary, usually incidental finding, non-painful unless cause fracture. Imaging gates, the film, we see the what we call it ground glass appearance, and there is sometimes flakes of ossification inside the cyst. The giant cell tumor, this is a neoplasm, also called the osteoclastoma, because it contains large number of osteoclasts like giant cell admixed with mononuclear cell, monocytes, macrophage. It is relatively uncommon benign tumor, but it's locally aggressive. These tumors are slightly more common in female. The patient age usually arise during the fifth decade, between 20 to 40 years. It involves both epiphysis and emphysis and commonly affect the long bone. It is a benign tumor with a aggressive behavior also. Pathological fracture may occur. The imaging, there is osteolytic lesion with ballooning, but the ballooning is less than the aneurysmal bone cyst. There is destruction and poor endosteal margin. There is also soup bubble appearance in the X-ray also appear. CT scan is diagnostic. If there is risk of malignant transformation, so we will see more destruction and poor endosteal margin with mitotic activity. The risk of malignant transformation is 5 to 10%. Microscopically, they appear brain tissue like in macroscopic in gross section, and material inside it like reddish color or brown with piece come in pieces, يعني friable tissue. Microscopically, the tumor is characterized by presence of oval mononuclear cell growing in a sheath mixed in with osteoclastic cell of giant cell. These are the osteoclastic like giant cell with multiple nuclei in it, and this is pathognomonic for diagnosis of giant cell tumor. Differential diagnosis: well, aneurysmal bone cyst, hydatid cyst, any cyst, metastatic. Management: need curettage with bone graft if it is subarticular and there is destruction of the joint, and in case of recurrence, so may we do joint replacement. Sometime with a curettage we need to inject the area and to clear the area using the hydrogen peroxide. This is the last slide in the lecture. Thank you for attention.